Okay, so my name is Jessie Briscoe. I'm PGY2 in critical care, one of the pharmacy residents. And today we'll be discussing the management of hyponatremia, a salty subject. Before we get started, I'd like to note that I have nothing to disclose. And we'll get started with a patient case. So we have a 72-year-old female with a past medical history of hypertension who presents to the ER complaining of nausea and vomiting for the last 4 days. She has a new onset headache and generalized confusion. And after further questioning, she reports that she's had a poor appetite since her husband passed away about 3 months ago. Her home meds are lisinopril and amlodipine. Her imaging is unremarkable, and her labs are significant for a sodium of 107, but are otherwise unremarkable. So the resident that's managing her care likely thinks that her hyponatremia is what's contributing to all of her symptoms, and she calls the pharmacy to ask for help with the following questions. The first one is, what's the most likely underlying cause of the patient's hyponatremia? What are the risks of treating or not treating her hyponatremia? What medication should we start? And how should we dose that medication? I don't know about you guys, but if I was just working on this off the top of my head, I probably wouldn't know the answers to these. But I hope that by the end of this presentation, you're able to identify the underlying causes of hyponatremia, classify different types of hyponatremia, and select an appropriate patient-specific treatment regimen for hyponatremia. There are numerous different ways to categorize and manage hyponatremia, but in order to maintain some semblance of continuity throughout this presentation, we'll primarily be utilizing the European Society of Endocrinology's 2014 clinical practice guideline on the diagnosis and treatment of hyponatremia. We'll also have some primary literature mixed in to help support our discussion, but you'll note that a lot of this literature that we're discussing is from the 2010s, so it's pretty dated compared to what we're usually talking about during a CE. I think that this topic is confusing enough for most of us that this is still valid for us to discuss and see how it impacts our management of patients in the future. Okay, so we'll get into the meat of it now. Since we're focused on sodium disorders throughout this whole presentation, I'd like to start by reviewing sodium and its physiologic role in the body. It's a major extracellular cation with normal serum levels of 135 to 145. In this presentation, we'll be discussing everything in terms of milliequivalents per liter, but I do want to note that you might sometimes see sodium reported in millimoles per liter, and these are equivalent. So if that ever comes up, just know that it's a 1-to-1 ratio of milliequivalents to liter to millimoles per liter. Sodium is osmotically active, and it's responsible for regulation of membrane potential and fluid balance within the body. Now, when we talk about sodium being osmotically active, it's important to understand osmosis and its clinical impacts. As a reminder, osmosis is the movement of solvent molecules through a selectively permeable membrane from a more concentrated solution to a less concentrated solution. This results in an equalization of solute concentrations between the two sides of the semi-permeable membrane. Because sodium is osmotically active, changes in serum sodium can result in massive fluid shifts within the body. Sometimes we can use those to our advantage, like we do when we utilize hypertonic saline in our patients who have cerebral edema, where it pulls water from the cells to help with the swelling that's happening in the brain. And sometimes the fluid shifts are less advantageous, like when a patient's serum sodium level is low, which can lead to fluid being pulled into cells, causing cerebral edema or cell lysis. So now that we've discussed the background of sodium, we'll move into talking about hyponatremia. So hyponatremia is broadly categorized as a serum sodium of less than 135. Additional classification is based on the tonicity of the serum, with hypotonic hyponatremia being classified as hyponatremia with an osmolality of less than 280, isotonic being classified as an osmolality of 280 to 295, and hypertonic being classified as an osmolality greater than 295. We'll spend most of our presentation today talking about hypotonic hyponatremia, but I do just want to briefly overview isotonic and hypertonic hyponatremia. So isotonic and hypertonic hyponatremia are typically caused by an excess of osmotically active particles in the blood, such as glucose, like what we would see in DKA or HHS, mannitol, like what we'd see with patients who are receiving cerebral edema treatment, glycine, which you might see following like large volume irrigation during urologic or gynecologic procedures, or hyperosmolar contrast. These particles are osmotically active and may impact changes in osmolality, but they're not associated with the large volume fluid shifts that we see with hypotonic hyponatremias. Typically, the hyponatremias that are caused by isotonic and hypertonic hyponatremia are translocational and resolve as the underlying issue itself is treated. The most common form of isotonic or hypertonic hyponatremia that we see in the hospital is likely hyperglycemic hyponatremia. So what happens with this hyponatremia is that as glucose rises in the serum, the body tries to maintain some semblance of normal osmolality. So it shifts sodium intracellularly, which results in translocational hyponatremia. As elevated glucose is treated and begins to return to normal, sodium shifts back out of the cells and the hyponatremia should autocorrect. If you do have a patient who has hyponatremia on their labs, but they're hyperglycemic, and you want to assess what their true serum sodium level is, there is an equation that can take into account their elevated glucose when calculating their serum sodium, and I've listed that here on this slide for your reference. Okay, so back to hyponatremia. We talked about hypotonic, isotonic, and hypertonic, but there's one additional form, which is pseudo-hyponatremia. So this is typically associated with an excess of solid particles in the blood, like triglycerides, cholesterol, or protein. And it's simply a laboratory abnormality. It's not actually indicative of a true hyponatremia. So if you have a patient who has excessively high triglycerides or cholesterol, and you do want to know what their true serum sodium is, there is a lab that I think we can send out to assess their actual serum sodium in the setting of elevated solid particles in their blood. All right, so now that we've discussed isotonic and hypertonic, we'll move into hypotonic hyponatremia and all of its different classifications. So hypotonic hyponatremia is broadly categorized as a sodium less than 135 and an osmolality less than 280. It can be divided into a normal of different classifications, but the first one that we'll start with is based on volume. So starting from the right, you can have patients who are hyponatremic and hypovolemic. This can be caused by non-renal sodium losses, such as vomiting, diarrhea, fistula losses, or sweat. Or it could be renal sodium losses, like from primary adrenal insufficiency or cerebral salt wasting. Moving to the right, you can see that euvolemic hypotonic hyponatremia may be caused by SIADH, or syndrome of inappropriate antidiuretic hormone, secondary adrenal insufficiency, hypothyroidism. I do want to note that with hypothyroidism, we're typically talking about severe hypothyroidism, like what you would see with myxedema coma, and not just someone whose thyroid levels are a little bit off. Additionally, you can have euvolemic hyponatremia from polydipsia, or drinking too much water, beer potomania, or drinking too much beer, a tea and toast diet, which is what you might see in elderly patients who have a normal fluid intake or but have a low solid intake. So they're drinking a normal amount, but they're not eating quite as much, and therefore they're not getting as much salt from their diet. And then the final reason that you could have a euvolemic hypotonic hyponatremia would be anorexia. These last four causes of euvolemic hyponatremia can be more broadly categorized into those caused by excess relative water intake. So again, simply having too much to drink and not enough solutes in the diet. The final form of hyponatremia based on volume is hypervolemic, which is typically caused by different states that cause edema. So for these, you would see things like heart failure, liver disease, nephrotic syndrome, or end-stage renal disease. While classification on volume status might be useful for determining your patient's cause of hyponatremia, especially for our critically ill patients, assessing volume status can be difficult. So as we move through the presentation, we'll look at some more objective measures to try to diagnose the underlying cause of hyponatremia. So after we talk about volume, the next way that we can classify hyponatremia is based on serum sodium level. So you can have mild hyponatremia, which would be classified as a sodium of 130 to 135, moderate, which would be classified as a sodium of 120 to 130, and then profound, which would be a sodium less than 125. The next classification that we can use is based on symptoms. And this, along with time, which we'll discuss in a moment, is significant because it can offer us the greatest insight into our patient's clinical status and how we should subsequently treat them. So starting from the left, you can have mild hyponatremia characterized by gait instability, forgetfulness, muscle cramps, or dizziness. Moderately severe, which is characterized by nausea, confusion, or headache, or severe, which would be characterized by vomiting, seizures, deep somnolence, a Glasgow Coma Scale score less than or equal to 8, or cardiorespiratory distress. Moderately severe and severe hyponatremia are significant because they're indicative of cerebral edema, which puts our patients at immediate risk of severe neurologic damage. This could include things like diffuse axonal injury, herniation, and even death. So managing their treatment appropriately is very important. The final classification that we'll talk about for hypotonic hyponatremia is classification based on time. So this is broken down into acute and chronic. Acute hyponatremia would be that has developed in less than 48 hours. And with this, the brain has not had a chance to adapt to the hypotonic environment. So really the greatest risk that you run with patients who have acute hyponatremia is the risk of not treating them, which could potentially cause cerebral edema. In terms of chronic hyponatremia, this would be hyponatremia that has persisted for more than 48 hours. The brain has had a chance to adapt to the hypotonic environment by extruding potassium, chloride, and organic osmoles extracellularly to maintain extracellular osmolality. These patients still have a risk of cerebral edema, but one of the more important clinical considerations is that when we treat these patients, we run the risk of osmotic demyelination syndrome. So what is osmotic demyelination syndrome? It was previously known as central pontine myelinolysis, and it typically occurs when we start to replace sodium in patients who have had chronic hyponatremia. These patients have adapted to their low sodium by extruding electrolytes and organic osmoles into the extracellular space. And when we start to replace their sodium, their brain is unable to quickly recapture all of those electrolytes and osmoles. And so they don't have any way to maintain any form of an osmotic gradient, which can result in dehydration and demyelination of white matter. Symptoms of osmotic demyelination may be mild, including dysphagia, dysarthria, tremors, or dizziness, or severe, such as pseudobulbar paralysis, spastic quadriparesis, catatonia, locked-in syndrome, or even coma. There are numerous risk factors for developing osmotic demyelination syndrome, but I think the one that we like to talk about the most is that of correcting sodium too rapidly. So traditionally, the thought was that if you corrected patients greater than 12 milliequivalents per liter of sodium, serum sodium in 24 hours, that they were at high risk of osmotic demyelination. But there are some studies that show that this might not actually be the case. So we'll talk about one of those in just a second. In terms of prognosis for osmotic demyelination syndrome, 94% of our patients survive, less than or equal to 40 get full recovery, and up to 30 have severe neurologic deficits. So when should you be concerned about the onset of osmotic demyelination syndrome? Typically, it occurs within 24 to 48 hours after sodium correction. And the management for patients who develop osmotic demyelination, which you can identify with an MRI if you're concerned about your patients developing it or that their symptoms might be indicative of it, is reintroduction of hyponatremia. So if you've corrected their sodium too fast, or you think that that might be the case, you can try to give them free water like D5W to try to correct their hyponatremia and reintroduce that hyponatremia so that their sodium isn't quite so high anymore. Additionally, you could consider the addition of Desmopressin, which we'll talk about a little bit more later. So I told you that there was a study that looked at patients who developed osmotic demyelination despite a correction rate less than 10 milliequivalents per liter per day. So these patients were corrected at a rate that was previously considered to be appropriate, but they still developed osmotic demyelination. This study was published by the American Society of Nephrology in the Kidney 360 Journal in 2021. And it included patients who had osmotic demyelination despite a 24-hour change in sodium of less than 10. They looked at 21 patients and compared risk factors and the rate of correction in this population. They found that 57% of patients had a sodium of less than 115, 33% had a baseline sodium of less than 105, 52% of patients had alcohol use disorder, 23% had hypokalemia, 29% had liver disease, and 52% had malnutrition. I do want to highlight that the alcohol use disorder and malnutrition are significant because these patients are typically depleted of thiamine, which is important for the maintenance of the myelin sheath, which is obviously important in osmotic demyelination. So these patients are likely at increased risk simply because they're thiamine deficient in addition to hyponatremic and being corrected. The authors also noted that the correction rate exceeded 8 milliequivalents per liter in 92% of patients with an initial serum sodium of less than 115 and 78% of patients with an initial serum sodium greater than 115. Based on the results of this study, they recommended considering thiamine for patients with malnutrition or alcohol use disorder and limiting sodium correction to less than 8 within the first 24 hours, since most of the patients who developed osmotic demyelination had correction rates between 8 and 10. Okay, so we'll come back to our patient case now. Again, she's a 72-year-old female with a past medical history of hypertension. She's had that poor appetite for 3 months and nausea and vomiting for 4 days, along with headache and confusion. Her serum sodium is 107, and now we know that her serum osmolality is 268. So how would you classify her hyponatremia, and then what are her risks of treating or not treating? So we can walk back through all of our different classifications just real quickly. So if we wanted to classify her based on volume, we know that she's had vomiting and diarrhea, and then potentially that tea and toast diet, along with some element possibly of anorexia due to her lack of appetite. So she could be hypovolemic or euvolemic. If we wanted to classify her based on serum sodium level, we know that at her serum sodium level of less than 125, she would be classified as profound. And then if we wanted to classify her based on symptoms, we know she's got nausea, confusion, headache, and vomiting. So she falls into categories of both moderately severe and severe, but since she has one severe symptom, that's how we would treat her. And then finally, based on time frame, we know that this has been going on for at least 4 days and potentially longer due to her lack of appetite. So we would classify her as chronic. All right, so now that we know how to classify hyponatremia, how do we treat it? So the first thing that you want to do is get your lab value back, and you find that your patient is hyponatremic, so their serum sodium is less than 135. And the first thing that you want to do is exclude causes of non-hypotonic hyponatremia. So in order to do this, you could utilize a serum osmolality if you have that back. So if your serum osmolality is greater than 280, you know that you have a non-hypotonic hyponatremia. If you don't have a serum osmolality back, though, you could assess if your patient might have an underlying cause of isotonic or hypertonic hyponatremia, such as excess glucose, recent administration of mannitol, glycine, or hyperosmolar contrast, or elevated solids in their blood that could cause pseudohyponatremia like triglycerides, cholesterol, or protein. So once you've done that and you've excluded all your causes of non-hypotonic hyponatremia, and you've confirmed that your patient does have hypotonic hyponatremia, the next thing that you want to do is assess the onset. So did your patient have an onset that would be considered to be acute of less than 48 hours? And if the answer to that is yes, then you would want to treat immediately. The guidelines actually don't make clear recommendations on how to treat acute hyponatremia. However, they do know that there's a low risk of osmotic demyelination and that it's acceptable to correct to the patient's baseline. So the general rule of thumb for acute hyponatremia is that it's okay to correct as quickly as it developed. So if your patient developed hyponatremia in the last 24 hours, it would be acceptable to get them back to their baseline within that time frame as well. If you go back to your graphic and you find that your patient did not have acute onset hyponatremia, the next thing that you would want to do would be assess the severity of their symptoms. So does your patient have moderately severe or severe symptoms? And I've listed those on this slide to your left, just for your reference. And if the answer to that question is yes, then again, you want to treat immediately. So we'll go through the guideline recommendations for moderately severe and severe hyponatremia. But I do want to note that our practice here is a little bit different than that. So we'll talk about that as we wrap this section up. So if you have moderately severe hyponatremia, the guidelines recommend giving 150 milliliter bolus of 3% hypertonic saline over 20 minutes, and then starting a hypertonic saline infusion. At this point, they would recommend checking serum sodium levels every 6 hours with a goal change in sodium of 5 milliequivalents per liter within the first 24 hours, which would likely result in symptom resolution. They also note that you should identify and treat your underlying cause. and limit your change in sodium to less than 10 milliequivalents in the first 24 hours and less than 8 every 24 hours thereafter until your serum sodium reaches 135. For severely symptomatic patients, the guidelines again recommend giving 150 milliliter bolus of hypertonic saline over 20 minutes, checking a serum sodium level, and then repeating 150 milliliter bolus of hypertonic saline. At this point, you again would check a serum sodium level and repeat hypertonic saline boluses until your change in serum sodium is greater than or equal to 5, or you've given 4 boluses of hypertonic saline. At this point, you would want to assess if your patient is showing signs of improvement. If the answer is yes, the guidelines recommend stopping the hypertonic saline infusion and starting KVO normal saline. They again recommend treating the underlying cause, checking sodiums every 6 hours, and limiting your change in the first 24 hours to less than 10 and less than 8 every 24 hours thereafter. If your patient does not show signs of improvement, at this point, the guidelines would recommend hypertonic saline infusion with a goal increase of 1 milliequivalent per liter per hour until your change in serum sodium equals 10 or your serum sodium reaches 130. At this point, if you still don't have improvement in your symptoms, they note that hyponatremia is not likely the underlying cause, and then it would be prudent to reconsider possible other causes of your patient's altered mental status or other symptoms. So we've talked a little bit about hypertonic saline infusions, but not so much about how to actually administer them. So we'll go into that. But first, we'll start with the sodium concentrations of different fluids. So you can see here that our plasma serum sodium is 135 to 145. And as we increase, you've got half normal saline that would provide 77 milliequivalents. Lactated ringers would be the most physiologically normal at 130. Normal saline would be a little bit higher at 154. And then you've got hypertonic saline, or 3% is what we typically use here, would have 513 milliequivalents per liter of sodium, while 23.4% would have 4,004. All right, so back to our patient case, same patient, same labs. You get an order that comes through for 3% hypertonic saline to run at 100 mils per hour with no stop time. The patient does have Q6 serum sodium checks ordered. Would you verify? Well, I haven't told you how to dose this yet, so you wouldn't know. But at this point, it's important to know how we decide how to calculate the rates that we infuse hypertonic saline in our hyponatremic patients. So the first thing that we can do is utilize the Adroge-Mattius formula. So this formula takes into account the sodium provided by the hypertonic saline, subtracts your serum sodium, and divides that value by total body water plus 1 to give an expected change in serum sodium. As a reminder, total body water is a composite of actual body weight and a correction factor, which is noted for multiple different populations on the box in the slide. So if we wanted to utilize this formula for the order that we got and our patient, we know that our patient is 72 years old. She's a female and she weighs 68 kilograms. And our order is for 100 milliliters per hour of hypertonic saline, which would end up being 2.4 liters per day. And we know that her baseline serum sodium is 107. So the first thing that we would need to do is calculate the amount of sodium that's provided by the hypertonic saline. So in order to do that, we know that 1 liter of hypertonic saline has 513 milliequivalents of sodium. And so when we calculate all of that out, we know that the amount of sodium in the hypertonic saline in 24 hours that would be provided by this order is 1,231.2 milliequivalents of sodium. The next thing that we would need to do is calculate her total body water. We would do that by multiplying her weight by her correction factor, and then we get 31 liters. And then when we plug that into the Adroge-Mattius formula, we would get that her predicted change in serum sodium would be 35 milliequivalents per liter. So I've told you that typically we target somewhere between 6 or 8 or 10 milliequivalents per liter in the first 24 hours. So this predicted change in serum sodium obviously exceeds that, and therefore I would encourage you to not verify that order. You could find an appropriate rate for the hypertonic saline by reworking the Adroge-Mattius formula, or you could actually calculate a rate of your hypertonic saline by utilizing your sodium deficit, which I think is what most of our clinical pharmacists here do. So to do this, you first would calculate sodium by your sodium deficit by multiplying total body water times your desired sodium minus your serum sodium. And then you would put that formula into this equation in order to get a rate. So for our patient, we would choose a desired sodium of 116 because we know that we don't want to correct by more than 8 milliequivalents, most likely within a 24-hour period. If we wanted to play it a little safe, we could have picked a change of 6. So it's important to note here that your desired serum sodium is what you would want your sodium to change within the first 24 hours or within a desired time frame. You wouldn't want to put like a normal serum sodium into this equation. So if we plugged all of our values in for this patient, when we calculate her sodium deficit, we would get 248 milliequivalents per liter. And then when we plug that in to get our rate, we would find that it would be appropriate for her hypertonic saline infusion to run at 20 mils per hour. And obviously throughout this process, we would continue checking serum sodiums and changing this as needed based on how she was responding. So do our equations work? There was a study that was published in 2007 in the Clinical Journal of the American Society of Nephrology entitled Hypertonic Saline for Hyponatremia, the Risk of Inadvertent Overcorrection. So this looked at 62 adult hyponatremic patients in a 528-bed acute care teaching hospital. These patients received 3% hypertonic saline, and they had a goal increase of less than 12 milliequivalents within the first 24 hours and less than 18 within the first 48 hours. They compared adherence to goal correction rates and the accuracy of the Adroget-Mattius formula. They found that 11.3% of patients increased by greater than 12 milliequivalents per liter in the first 24 hours. So according to their goals, they overcorrected. And 9.7% of patients increased by greater than 18 milliequivalents per liter in 48 hours. So again, an overcorrection at 48 hours. There were no patients who increased by more than 25 in 48 hours. But the authors did note that if initial serum sodium was less than 120, the increase in sodium exceeded the prediction of the Adroget-Mattius formula by 74.2%. In fact, the average overcorrection was 2.4 times the predicted correction, and 40% of the overcorrection was likely secondary to excess water diuresis. So that begs the question, what is excess water diuresis? And if it impacts overcorrection in 40% of our patients, what can we do to prevent it? So in order to understand that, we have to first understand the pathophysiology of overcorrection, which is most common in patients who have hypovolemic hyponatremia. So in hypovolemia, your brain senses a lack of perfusion and flow volume. And so it releases antidiuretic hormone to try to hold on to as much fluid as possible to try to better perfuse. When we give fluids for hyponatremia, those subsequently help restore intravascular volume, and the body recognizes sufficient fluid for perfusion. And so it turns off that ADH production that it had previously started, which results in fluid dumping. So this would be characterized by a urine output greater than 100 mils per hour. And fluid dumping is significant because it changes the patient's physiology, which results in overcorrection. So when we've calculated our rates of correction using one of the aforementioned formulas, we assume a steady total body water, but dysregulation of ADH changes the patient's physiology and leads to fluid dumping and subsequent overcorrection. In short, it means that we're trying to hit a moving target. So the question is there anything that we can do to stop that target from moving? And the answer is yes. We can use DDAVP or Desmopressin. So Desmopressin is an analog of antidiuretic hormone, arginine vasopressin. It increases cyclic AMP in the renal tubule, which results in increased water permeability, decreased urine volume, and decreased urine osmolality. It's dosed at 1 to 2 micrograms every 6 hours. We're talking about utilizing it for preventing sodium overcorrection. But I do want to note that this is significantly different than the dose that's utilized for hemostasis, which is 0.3 to 0.4 micrograms per kilogram. So dose is usually somewhere around 20 micrograms. So when you're verifying orders for DDAVP, just make sure that you double check what the indication is to ensure that your dosing is appropriate. DDAVP has a half-life of 2 to 4 hours and a duration of 6 to 14 hours. And the goal of utilizing it is to remove the variability of the intrinsic ADH production and allow electrolyte-free water excretion at a constant level. So the next question is, does it actually work? So there was a study published in 2014 in the Clinical Journal of the American Society of Nephrology entitled The Use of Desmopressin Acetate in Severe Hyponatremia in the Intensive Care Unit. This study looked at 20 severely hyponatremic patients in Paris, France, who had a median baseline sodium level of 109. This study utilized a reactive DDAVP administration. So they only started DDAVP after they had started hypertonic saline and their patients showed signs of overdiuresing or overcorrecting, which is a little bit different than what we typically do here. For comparison, the authors wanted to look at serum sodium control before and after DDAVP. In terms of outcomes, they found that most patients received 2 to 4 micrograms per dose at a median interval of 25.5 hours, and that they achieved a change in serum sodium less than 12 milliequivalents per liter at 24 hours in 80% of patients, and less than 18 milliequivalents per liter at 48 hours in 100% of patients. And as you can see, after administration of DDAVP, urine output decreased significantly. Change in serum sodium also decreased significantly. Urine osmolarity went up and sodium variation went down as well. There was another study published in 2013 in the American Journal of Kidney Disease entitled Hypertonic Saline and Desmopressin, a simple strategy for safe correction of hyponatremia. This study looked at 25 patients with serum sodiums less than 120 at a community teaching hospital, and they used a different strategy of proactive DDAVP administration where they started DDAVP at the same time they started hypertonic saline, and they compared rate of correction and then predictability of the serum sodium response utilizing the modified Adrogen-Mathias formula. The mean change in sodium in the first 4 hours was 2.6, and in the first 24 hours was 5.8. In the second 24 hours, it was 4.5. So all values that would be within our goal ranges of correction. There were no patients who corrected greater than 12 milliequivalents per liter in 24 hours or greater than 18 milliequivalents per liter in 48 hours. However, there were 2 patients who did exceed 10 milliliters per hour within the first 24 hours. Additionally, there were no net decreases in serum sodium after initiating DDAVP and hypertonic saline, and there were no differences in predicted versus actual change in serum sodium within the first 24 hours. There was a slight difference in the second 24 hours where the patients who received DDAVP corrected a little bit more than the formula predicted, but this was right on the baseline of right on the line of statistical significance and could have been because of patients receiving different DDAVP doses after the first 24-hour mark. The final study that we'll look at for DDAVP was published in 2015 in the American Journal of Medicine. That was Desmopressin to prevent rapid sodium correction in severe hyponatremia, a systematic review. So this study broke the patients who received DDAVP down into 3 different groups. One were those who received the proactive strategy, where DDAVP and Hypertonic were started at the same time. Others were the ones who received a reactive strategy, which is when DDAVP was started when urine output became high or the patients were experiencing a high rate of sodium change but had not yet overcorrected. And then the final group were those who received sodium as a rescue. So they had either already overcorrected or they were showing signs of osmotic demyelination. So if we look at the proactive group, you can see that before and after administration of DDAVP, our change in serum sodium at 24 hours was about 7. Only 6.9% of patients had relowering of sodium after initiation of DDAVP. And then most patients, or 27.6% of patients, did correct at a rate of greater than 8 per day, but only 10.3% corrected more than 12 milliequivalents in the first 24 hours or more than 18 in the second 24 hours. When we look at the reactive group, you can see that these patients were, again, already starting to overcorrect. So their change in serum sodium before DDAVP had started was 9, and after DDAVP it had lowered just a little bit, so we changed their rate of correction appropriately with administration of DDAVP. And in this group, 57.6% of patients experienced relowering of sodium after the initiation of DDAVP, which was likely the intention given that they were already beginning to overcorrect. And finally, in the rescue group, so these patients had already overcorrected or again had signs and symptoms of osmotic demyelination, the addition of DDAVP successfully resulted in relowering of sodium in 93.8% of these patients. The mean baseline sodium across all of these strategies was quite low at 111.7. There was one high-risk patient in the reactive group that did develop osmotic demyelination, and 4 patients, or 25% of the rescue group, developed symptoms of osmotic demyelination that did subsequently correct with relowering of sodium. And the most common adverse reaction of DDAVP in this study was unintentional sodium relowering, but this tended to be mild and was not associated with any adverse effects. So based on the results of this study, it seems that utilization of a proactive strategy can help prevent overcorrection in the first place. And a reactive or rescue strategy may assist in preventing overcorrection in our patients who have already shown signs that they may overcorrect. So based on the results of this study, Duke has actually started utilizing a protocol for DDAVP in their patients with hyponatremia. They don't use this in patients who are volume overloaded or severely symptomatic, but their protocol is as follows. So they stop any maintenance fluids, then they start DDAVP at 2 micrograms IV every 8 hours, and then they start 3% hypertonic saline, which they begin on a weight-based dose of 1 to 1.5 mils per kg over 6 hours. They make sure these patients are fluid restricted to less than 1.2 liters per day, and then monitor sodium levels every 2 hours initially, and then decrease that as sodium begins to stabilize. They adjust their infusion rate based on the sodium levels that they get and continue DDAVP until the sodium is 125 to 130. Our practice here at Erlanger is highly provider dependent, but it typically starts with a bolus of 150 milliliters of hypertonic saline over 15 minutes, followed by a hypertonic saline infusion, which is usually calculated using one of the formulas that we previously talked about. Typically, we target a goal change of sodium of 6 to 8 milliequivalents per liter per day. We err on the lower side just in case of overcorrection to try to prevent that, and then have a little bit more wiggle room in case that we do overcorrect. And some of our providers utilize DDAVP, while some of them tend to utilize only hypertonic saline. We are working on a protocol to try to standardize things a little bit. So hopefully, based on the results of the MUE that I'll be doing later this year, that will be out at some point in the spring. So what do you do if your patient overcorrects? So this would be a change of more than 10 milliequivalents per liter in the first 24 hours, or 8 in any 24 hours thereafter, according to the guidelines. But again, here, we typically target more of a goal of 6 to 8. The first thing that you should do is discontinue ongoing treatment. The next thing that you can do is consider initiation of D5 at a rate that's dependent on the free water deficit. You can find free water deficit calculators on MDCalc, or you can utilize the sodium deficit equation as well. If DDAVP has not already been initiated, you can consider giving 2 micrograms to prevent additional fluid losses and subsequent overcorrection. And this process would be very similar to what you would do if your patient started exhibiting signs of osmotic demyelination as well. Okay, so we've talked about acute and severely symptomatic hyponatremia. And the last thing that we'll talk about is the management of chronic hyponatremia. So when your patient has hyponatremia, the answer is just to sprinkle a little salt on it, right? Okay, so going back to our graphic, we have our patient who has hyponatremia. We've excluded causes of non-hypotonic hyponatremia, and we've also excluded patients who have acute and severe symptoms, and we've already treated them. So these are just our chronic hyponatremic patients who are not having severe symptoms and who have hypotonic hyponatremia. The next thing that we want to do is get a urine osmolality. So if your urine osmolality comes back less than 100, this would indicate to you that your patient has maximally dilute urine and would likely be due to relative excess water intake. So this could be due to psychogenic polydipsia, like they're just drinking too much, beer-potomania, that tea and toast diet that we talked about earlier, or anorexia. So as you start to give these patients more sodium, their hyponatremia should begin to correct. If your serum sodium is greater than 100, the next thing that you would do is get a urine sodium. So if your urine sodium is less than 30, this would be indicative of a low effective arterial blood volume And this could be because of one of two reasons. So your patient might be extravascularly overloaded, but intravascularly depleted, like what we see in patients who are hypervolemic due to liver disease, heart failure, or nephrotic syndrome. Or they could simply just be hypovolemic due to diarrhea, vomiting, fistula output, or third spacing. And so we'll talk more about how to treat those two different types of hypovolemia in a second. If your urine sodium is greater than 30, the first thing that you would want to do is exclude diuretics and kidney disease. So diuretics can throw off your urine sodium. So for patients who have recently had diuretics, you would actually want to order an FE urea instead of an FE sodium. So for those patients, you would want to consider that. But after you've excluded other things that might cause increased urine sodium, the next thing that you would do is assess your patient's volume status. So if your patient appears hypovolemic, their underlying cause might be vomiting or primary adrenal insufficiency or cerebral salt wasting. If they're euvolemic, they could have an underlying cause of SIADH, which we'll talk about more in a minute, secondary adrenal insufficiency, or severe hypothyroidism. We've come to our first test your knowledge question. So CW is a 28-year-old male who presents following completion of an Ironman with complaints of headache and nausea. His labs are as follows. So serum sodium is 127, and you have the normal values over to the right. His serum osmolality is 272, and his urine osmolality is 22. What's the most likely etiology of his hyponatremia? So we have A, syndrome of inappropriate antidiuretic hormone, or SIADH, B, relative excess water intake, C, nephrotic syndrome, or D, cerebral salt wasting. So for him, his most likely cause is relative excess water intake. We know that he has just recently done an Ironman, and so he potentially missed some stops for his electrolytes and continued drinking other fluids. But because his urine osmolality is 22, we know that that's significantly low, which likely indicates relative excess water intake. So our answer is B. All right, same patient. Upon further questioning, he notes that he did drink plenty of water throughout the race, but he missed multiple stops for electrolyte replacement. How would you classify his hyponatremia? So does he have A, hypertonic hyponatremia, B, euvolemic hypotonic hyponatremia, C, hypervolemic hyponatremia, or D, pseudohyponatremia? Any guesses? So we know that his serum sodium is low and his serum osmolality is less than 280, which would be indicative of hypotonic hyponatremia. As far as we know, he doesn't have any underlying causes of something that would make him hypervolemic, like liver disease or renal failure. So the most likely underlying cause for him, since he was drinking plenty of water throughout his race, would be euvolemic hypotonic hyponatremia. That's most likely caused by simply missing some of those stops for his extra electrolytes. Okay, so you have a patient who has chronic hyponatremia. How do you manage them? So we talked about all of the more acute managements of hyponatremia, but general management of our patients with chronic hyponatremia, the first thing that we do is stop fluids and then any other medications that could contribute. Things that you want to consider here, again, is thiazide diuretics, as these can make you lose salt and potentially cause hyponatremia, and then consider other medications that might be causing salt wasting as well. The next thing that you want to do is identify and manage your underlying cause. In terms of mild hyponatremia, so serum sodium of 130 to 135, it's unnecessary to treat with the sole aim of increasing sodium. In terms of moderate or profound hyponatremia, a sodium less than 130, the first thing that you would want to do is initiate a hypertonic saline infusion. According to the guidelines, your goal change in serum sodium for the first 24 hours would be less than 10, and for every 24 hours thereafter would be less than 8. This changes a little bit for a few different disease states. So if your patient is fluid overloaded, the first thing that you would want to do actually is initiate fluid restriction. And you would want to avoid treating unless they had profound hyponatremia or a sodium less than 125. And the reason that the guidelines make a recommendation for this is simply to avoid administering excess fluid in a patient who's already fluid overloaded. In patients who are hypovolemic, they're also a little bit different. So for them, you would want to initiate normal saline or balanced crystalloids at 0.5 to 1 mils per kg per hour to restore their intravascular volume. If they're hemodynamically unstable, the need for rapid fluid resuscitation overrides the risk of overcorrection and subsequent osmotic demyelination. Like we talked about earlier, patients who are hypovolemic do have those changes in ADH, which put them at high risk of overcorrection. So this could be a good population to consider use of DDAVP in as a proactive strategy. The last exception to the general rules of management, and the last thing that we'll talk about today, is the management of syndrome of inappropriate antidiuretic hormone. So this is characterized by unsuppressed release of vasopressin, which results in volume retention and sodium excretion. It can be caused by a wide variety of things, like CNS disturbances, including stroke, hemorrhage, or trauma, malignancy, like small cell lung cancer, drugs like carbamazepine, oxcarbazepine, cyclophosphamide, or our SSRIs. Additionally, surgery, pulmonary disease, hormone disturbances, and genetic abnormalities can also cause SIADH. Previously, diagnosis of SIADH was done with an isotonic fluid challenge. So, with an isotonic fluid challenge, you would give 1 to 2 liters of an isotonic crystalloid. And if the serum sodium went up, that would indicate to you that your patient had dilute urine and an excess water to solute intake. And if your sodium didn't change or went down, that indicated that your patient had concentrated urine and it was likely SIADH. However, this is really no longer recommended for diagnosis of SIADH, and there are a couple reasons for that. One is that when you give patients isotonic crystalloid, if they do have SIADH, there is the possibility of dropping their sodium lower, which in patients who are already at risk of cerebral edema would be a significant adverse effect and put them at increased risk. And the other is that it doesn't always work the way that we think that it does. So a lot of whether or not your sodium goes up or stays the same or goes down is dependent on your urine osmolality. And so sometimes even patients with SIADH might have a little bump in their serum sodium after an administration of 1 to 2 liters of isotonic crystalloid, but they still would have SIADH. So in short, isotonic fluid challenges are no longer recommended for diagnosis. The diagnosis of SIADH is one of exclusion, but there are some criteria that you can utilize if you've narrowed down all of the other reasons of hypotonic hyponatremia and you're not sure what your patient has. So you could consider SIADH if your patient had a serum osmolality less than 275, a urine osmolality greater than 100, clinical euvolemia, urine sodium greater than 30, and the absence of adrenal, thyroid, pituitary, or renal insufficiency, and no recent use of diuretic agents. In terms of treatment of SIADH, the first line is fluid restriction of less than 800 milliliters per day. And we have a couple of different options for second line treatments. The first one is urea, and the second is low-dose loop diuretics and oral sodium chloride tablets. If you ever need to know and you've calculated your sodium deficit, a 1 gram salt tab has 17.1 milliequivalents of sodium. Of note, vasopressin receptor antagonists are no longer recommended for the syndrome of inappropriate diuretic hormone. So I told you that you could use urea for SIADH treatment, so we'll talk about it just for a second. Urea induces osmotic excretion of free water. And in SIADH, it increases medullary urea content and results in diminished natriuresis. So in short, it can help your body hold on to sodium. It's dosed at 0.25 to 0.5 grams per kilogram per day and should be avoided in renal dysfunction or patients with a GFR of less than 40 to 60, cirrhosis, and hepatic encephalopathy. There was a study published in 2010 in the Journal of Crit Care that looked at the treatment of euvolemic hyponatremia in the intensive care unit, and they split it down into 2 different groups. So in the first group, you had mild or moderate SIADH-induced hyponatremia in the ICU, and they defined this as a serum sodium of 120 to 134, and they wanted to look at the administration of isotonic saline plus urea, and then compare serum sodium, fluid intake, duration of therapy, and the development of hypo or hypernatremia. They found that the serum sodium at urea initiation versus day 2 was significantly higher after urea initiation. So at initiation, it was 128, and then at day 2, it was 135. And the mean change in 24 hours was 2, mean change in 48 hours was 7. The urea dose was a median of 46 grams per day, and the duration of urea was typically 6 days. 12% of patients had hyponatremia following urea discontinuation, and 12% of patients had hypernatremia while on urea. The second group that this study looked at were patients with chronic severe hyponatremia that was developed pre-admission. They defined this as a serum sodium less than 115. And they again looked at isotonic saline and then compared the same endpoints. They found that serum sodium at urea initiation versus day 1 went up significantly by almost 11 points. And the change in serum sodium at 24 hours was greater than 12 milliequivalents in 34% of patients, and at 48 hours was greater than 18 and 51% of patients. However, they didn't note any incidents of osmotic demyelination syndrome. So I think based on the results of this study, it's reasonable to consider urea in your patients with hyponatremia that is not severe. So your patients who are a little bit more stable and don't require as much of a change in sodium and potentially don't have as low of a serum sodium as you saw in the second group, utilizing urea for SIADH is definitely a reasonable option. The last thing that we'll talk about is why vasopressin receptor antagonists are no longer recommended. So vasopressin receptor antagonists are tolvaptan and conivaptan. They work by promoting excretion of free water, which results in net fluid loss, increased urine output, decreased urine osmolality, and restoration of sodium levels. There are significant safety concerns with vasopressin receptor antagonists. Of note, they can only be utilized for 30 days. There is a risk of rapid sodium increase that's 60% higher in patients who are treated with these drugs. In March of 2020, tolvaptan's manufacturer released a statement regarding reports of neurological sequelae in patients who overcorrected while on its drug. And then tolvaptan has also been associated with significant hepatotoxicity. There was a study published in 2011 in the American Journal of Medicine that looked at short-term efficacy and safety of vasopressin receptor antagonists for the treatment of hyponatremia. This was a meta-analysis that assessed 11 trials in over 1,000 patients and compared vasopressin receptor antagonists versus placebo. They noted that their change in serum sodium at day 1 was 3.3, and at day 2 it was 4.2. And the odds ratio for rapid overcorrection of sodium was 3.0. They found no reduction in death, and they also didn't find an increased risk of adverse effects, along with no reports of osmotic demyelination syndrome. So the results of this study really show that while vasopressin receptor antagonists might change serum sodium levels, it doesn't really change patient outcomes. And it puts patients at significant risk of hepatotoxicity and overcorrection, which is why these drugs are no longer recommended by the guidelines and are not commonly used for SIADH anymore. Okay, last thing, it's a test your knowledge question, but I made this one easy for you guys. So you have a patient who presents with seizures and vomiting. Labs indicate a serum sodium of 107. What's your next step with regard to her sodium management? Do you want to A, fluid restrict, B, start normal saline, C, start hypertonic saline, or D, start urea? C, yes. So that is the correct answer. And that's the end of my presentation. So now I'll open up the floor for questions. Yes.
You talked about different protocols, some of these boluses, all about infusion. As you mentioned, some boluses. Are there some that just use Hypertonic, or what's the strategy as far as bolus?
I think for patients who are moderate. Oh, yes, sorry. The question was, what's a better strategy in terms of using boluses and then infusions of hypertonic saline or just infusions alone? For patients who are moderately or severely symptomatic, who are showing signs of cerebral edema and subsequent decompensation, I think utilizing a bolus and then starting an infusion would be more appropriate to try to more quickly correct their serum sodium. And patients who are more chronic and not showing signs of cerebral edema, just starting with a sodium or a hypertonic saline drip, I think would be appropriate.
Thank you for such a riveting topic. My favorite subject. How would you manage a patient that came in with a traumatic brain injury who presented with a sodium of 120 who they wanted to treat with hypertonic saline for TBI?
Bree's question is, what would you do with a patient with a traumatic brain injury with a sodium of 120 that they wanted to use hypertonic saline for TBI? That's a great question, Bree. I guess you could ask the same question for like patients with strokes that you're worried about cerebral edema in. I guess you would have to weigh your benefits and risks. So is your risk of cerebral edema going to be greater than your risk of osmotic demyelination? I would assume in a patient with a traumatic brain injury who's swelling and could possibly herniate, the answer would likely be that your risk of cerebral edema would be greater. But I guess it would be more patient dependent.
What is our risk of cerebral edema highest?
She asks, when is your risk of cerebral edema highest in those patients? Isn't it like a biphasic curve? One starts at, is it 24 hours? 72, and then where's the second one?
That is 7 to 10. But you could and you should not exceed still that 8 milliequivalent per hour correction. That is a period of time there when your peak swelling in the initial result.
So would you still be a little bit more aggressive, or would you stick with like 6 to 8?
I think that's important when you're verifying and looking at orders, because we're very quick to order like the titration scale for nursing for trauma patients that come in. And the target on that titration is a sodium of 150. So we don't want to take somebody and have the nurse titrate up that drip with every sodium check to drive their sodium to 155 if they come in with a sodium. That protocol really shouldn't be used if there's sodium less than 100.
Is that built into the protocol?
Not built into the protocol.
Brittany.
So I also want to say thanks for breaking down like a really complex topic. And I probably approach it a lot differently than what specialty practice with. One of my favorite parts of this was just the emphasis on how pharmacists should approach verifying rates for hypertonic sodium infusions. What kind of support are we currently providing to our staff pharmacists? Do we have a standard recommendation for how to verify and calculate hypertonic saline infusion rates, or is that something that's entirely by protocol that's ordered by the provider?
Brittany is asking if we have support for our staff pharmacists and clinical pharmacists in terms of managing hypertonic saline drips. And is that all? Or if there's like a protocol built into it?
For calculating rates and verifying the order rate against.
Yeah, for calculating rates and then verifying against what the rate was ordered. As far as I know, we do not have any form of calculator built in, but that would definitely be something interesting to consider following my MUE and then subsequent protocol development. And then I don't know about for TBIs, Bree, is that something that we could look into? Okay.
One more comment about urea. Urea is a great drug. If you do end up putting somebody on it, work with case management, because sometimes these patients will have to go to rehab, or even if they're discharged home, a lot of the pharmacies don't carry it, but they will order it for you. So you send people to rehab, you just need to work
Indications for hypertonic saline boluses. I've had some scenarios when I'm just during order verification when the bolus may be a part of the protocol, but the provider elects not to order it, and there may be a disagreement among providers on whether or not it's administered. So what would be your advice to pharmacists who may not have a lot of inside information to the patient? Maybe they are just in an emergency room or how to distinguish whether or not someone should advocate more aggressively for administering bolus dose.
Brittany's question is, when should we administer bolus dose versus not? I think what you might be talking about is the hypertonic saline for like TBI protocol, which is a little bit different than management for hyponatremia. That's built into the TBI protocol. So it's based on the patient's serum sodium level. I don't know what the cutoff is. Is it 135?
Yeah. So that's kind of a loaded question because the other thing you have to consider is what other fluids has that patient already got? Have they got, 5 units of blood that have all been chased by 250 things? Has EMS already given them 2 liters of crystalloid before they hit your door? And so I have actually seen, we had a patient a few years ago that developed OBS and was like severe OBS. And it was really due to all the excess fluids that people don't really think about. So that could be a consideration. If the TBI isn't really that severe and they're just want to put granny on a 3% growth for 24 hours, they probably won't bolus her. She probably didn't fit in the first place, but but that they're giving that for TBI, not necessarily for hyponatremia. Question really with providers just in general.
Okay, thanks guys.